respond to.
We do not have public comment. We're not open for comment right now. So you're just gonna you're gonna move a second to open session.
Yeah.
Great.
Yeah.
There. You're all set.
All right. Is there a motion to resume open session at 12:09 a.m.?
So moved, Board Member Chin.
Yeah.
Sorry, let me repeat that. Is there a motion to move to resume open session at 12:09 p.m.?
So moved, Board Member Chin.
Is there a second?
Second, Board Member Pinedo.
Board Member Joyce, yes. Board Vice President Kirkbride?
Yes.
Board Member Chin?
Yes.
Member Hall?
Yes.
Board Member Kroger?
Yes.
Board Member Patel?
Yes.
Board Member Pinedo?
Yes.
Motion passes with Board Member Smith absent. We will now review and discuss proposed temporary rules, board excluded protocols, and standard vaccination protocols with Executive Director Runyon.
Executive Director Runyon, thank you all for being here, especially on such short notice. And it's good to see some familiar names and not any faces on the public side of things. While staff member Melvin gets everything pulled up, we'll just go ahead and talk about why we're all here. Of course, there have been a lot of structural and ideological changes at the federal level, and that's caused delays in the issuing what can sometimes be unpredictable guidance. And that's caused critical barriers to access for preventative care, namely in relation to pharmacist-based vaccinations available to the public. So to circumvent these issues, on September 3rd, we entered into an alliance with California and Washington called the West Coast Health Alliance. And I think on September 4th, Hawaii joined. So between the four of those, the WCHA is issuing recommendations for the 25-26 respiratory virus season. And these recommendations that you'll see momentarily are informed by trusted national medical organizations, including the American Academy of Pediatrics, the American College of Obstetricians and Gynecologists, and the American Academy of Family Physicians. The WCHA reviewed vaccine effectiveness, epidemiological and safety data, and national medical organization recommendations to arrive at these consensus recommendations. And the WCHA believes that all recommended immunizations should be accessible to the people of our states. So in general, before we get to the protocol recommendations, I'll give you an overview of the steps that it took to facilitate this process. Essentially what we're doing is we're removing from Division 102, we're creating carve-outs for these protocols, in other words, or exceptions to that limited board delegated authority. We're also removing these three carve-outs from the universal vaccine protocols. We'll then remove the three vaccines from our rule set, and then we'll add protocols and then add them to the corresponding rules. Also, in terms of the protocol itself, essentially what we've done in overhauling them is just taking out the ACIP recommendations and then inserting the relevant WCHA recommendations in their place. So here we have the Division 115 protocols, and we'll scroll down a little further and you'll see where the formulary items and the protocols are listed. So you'll see the dates are going to be updated to today, because as we pull those out, they will be updated with today's date to show that change. And then underneath in 5, we'll create a space for the board excluded vaccine protocols, and that exclusion is going to take place in Division 102, which I believe is going to be next up.
Mm-hmm. Do you want to ask questions on this, or you want me to close it and open the next one?
Are there any questions on this? Or?
Sorry, I can't see.
So here we have Division 102, and this was adopted, I believe, the August board meeting and was part of the push to move to the universal protocols. So this allowed the board president to delegate limited authority related to essentially updating vaccine protocols in alignment with ACIP and or CDC recommendations. So that could be bestowed by the board president to board staff, and this was a pivotal component in our ability to update these protocols absent of the PFAC or board's direct involvement to help kind of streamline and expedite the process. So here, all we're doing is you see that the by the bold and underlined text is we're creating a carve out for those protocols you just saw in part 5 of the 115 rule. So we'll create the exception here, and those will be reflected in the previous rule. Okay, and next we will review the first protocol. You'll notice the format's very similar, and this is the format that we had, I believe, in June prior to updating to the universal protocols. So numbers 1 through 9 are going to be the exact same, not only as they were in June, but also between all 3 protocols that we're going to review today. And there's very little that was added. The majority of the changes involved an excision of all ACIP references and related material. So here you'll see in number 1, again, this is the same across the board. We have mention of the West Coast Health Alliance and what it is and what other primary resources that it utilized in creating those recommendations. Then we have in each of the protocols some information that might be new since the last update. So for here we have the age restriction as mentioned previously due to the PrEP Act. Again, if you're not familiar, the PrEP Act mandates that covered products or covered individuals are ones that vaccinate with FDA approved and ACIP or CDC recommended vaccines. So we don't have the current ACIP recommendations for COVID, so that would exclude COVID being under that umbrella. So that's why you see the individuals 7 years of age and older here, whereas the protocol in June, I believe, was for 3 and up as appropriate. And then we have the immunization protocol. This is essentially just very high level text representation of the recommendations in the vaccine schedule, which is number 3. And this is a direct copy and paste from the West Coast Health Alliance recommendations. And I'll add, this is really in line with the FDA approval, except for, when we scroll down, one of the biggest differences is that individuals 2 through 64 without a high-risk condition, if they want protection, can get the vaccination, whereas I believe under FDA authorization, it requires that they have one of the high-risk conditions as they determine. So that's one of the key differences here, and this is actually in line with the OHA protocol, their model protocol that's currently active. You can find it on the website because they allow individuals 2 through 64 without underlying health conditions under the shared clinical decision-making model to get vaccinated if they simply want additional protection. And we go into detail as to what constitutes shared clinical decision-making or some constitutional elements of that in number 4. And it's also referenced, I believe, in Appendix B further down. So you have some outlines there. It's also linked in, it's reference 6. And then one of the things I like to point out as well, some of the auxiliary topics, if you will, like pregnancy and lactation, warnings and precautions, contraindications, a lot of those reference the ACIP recommendations. So we took those out and then we relied on the package insert where appropriate. And because a lot of those were covered, just not as succinctly across the entire spectrum of approved products, but they were covered in the package insert. So we left as many of those references as we can, and we put in some generic language. You'll see at the bottom of each of those sections, see current prescribing information for more details about contraindications, storage and handling, pregnancy and lactation, et cetera. Again, 7 and 8, those are all the same as they were in June. So very little information added, most of the information taken out. There are all the references, and then we can scroll down past that for the 3 additional appendices, if you will. And these are all cut and pasted from the WCHA recommendations. And there's the reference to the shared clinical decision-making I mentioned earlier. And that primarily refers to extra doses or additional doses, rather. And just removing some references there. All right, and that's the end of the COVID protocol.
We want discussion, or you want me to open the other 2?
I'm just gonna go ahead and go around, starting with our vaccine expert, Board Vice President Kirkbride.
Not sure if that's deserved or not, but I'll take it. I actually do have a question on that shared clinical decision-making piece. We've been previously told with these older version of our vaccine protocols that we need to be really clear with the guidance, that we can't have just like use shared clinical decision-making. So is there somewhere that kind of lays out the decision-making for that shared clinical decision-making so that is clear for pharmacists what pathway they take? Because I think that was the advice before with our protocols, that it had to be like laid out.
That's Executive Director Running. I believe we have that link. It's should be reference 6 under section 9. And I believe that will take them to the CDC site that outlines what that might look like. I don't know if you can.
Can you see that, Board Member Kirkbride?
I do see that, but that's just a description of the definition of shared clinical decision-making. That's not the COVID guidance.
Executive Director Running. I'm not aware that they have any COVID specific guidance since it would have been December of 2024. Published in that MMWR. I think that's the most recent COVID publication we had from the CDC in terms of the MMWRs anyway. So the outline in the protocol, and then all of the FAQs here are all of the resources that we have, or that I have.
Okay, I guess I'm just a little unclear what they are using shared clinical decision-making for then. But you
It's
can
the
keep going.
additional doses portion, and I think that was actually covered right there. Additional doses of COVID-19 vaccination for people who are moderately or severely immunocompromised, and I believe potentially for, if we go back to the protocol, individuals 65 and up who want one. Yeah, that should be in the first section 3, the first chapter. Probably in the big one. Yeah.
Perfect. I see it right there. Reference 5. should receive a second dose 6 months after. That's the shared clinical decision-making piece right there.
Yeah, and it's mentioned in Appendix B as well that I pointed out
Okay.
earlier. We're happy to scroll down.
Okay.
I think it's the very bottom of Appendix B.
Yeah, if that is the connector, then that's perfect. Okay.
Alrighty, Board Member Chin,
Yes, sir. No
questions?
questions.
Questions, okay. Board Member Hall,
I don't have any additional questions. Thank you.
Board Member Kroger,
Board Member Kroger, this document is not available within our board packet or board materials, correct, for review?
Yeah, that's correct, Executive Director Runyon. We were, or I say we, I handcrafted this bespoke set of vaccine protocols, if you will. I was on a very tight timeline and didn't finish until this morning. I stayed late last night and finished early this morning. So unfortunately, they were not included in there. I would apologize for that, but appreciate the understanding.
And this is Staff Member Melvin. Board Member Kroger, we also had to present them to the formulary committee during the meeting prior to this.
Excellent. Yeah, I appreciate the work, Gary. I really do. I think even 10 minutes, 15 minutes before the meeting, or even during the meeting, having access to this document so that as we're talking and considering, I'm able to scroll through would have been really helpful to digest this. This is a lot. I want to make sure that this is done right. This is, I think, hugely important and impactful to all of the people here in Oregon to make sure that this is done in a way that's going to resolve the issues and protect as many people who want to be protected as possible. With that said, can we scroll down just a little bit here under the vaccine schedule? I just wanted to, I need some more time. No.
Oh, I thought you wanted which section?
No, this chart here. I just wanted to, because this is typically, from my experience, this is what this is the kind of the go-to, like, really quick pharmacists are going to take a look at this to make sure that they're understanding what they need to do. So I just need a minute to digest this. And then can you scroll down a little?
Yeah.
To the next page. Okay, I have no further questions. But I've said before, it's important to me as a board member to be as well prepared for these meetings as possible. And I understand the tight timelines, and I absolutely appreciate the time and effort and late nights and early mornings that the board staff has been putting into this. But it's still, like I said, at any point, if we can get, have this added to the packet for reviews, it would be appreciated. Thank you.
Executive Director Runyon, thank you.
Board Member Patel,
Yeah, Board Member Patel, I'm also going to echo whatever Board Member Kroger said. In my situation, as you guys know, I'm unable to connect through the iPad. I'm on the phone and I cannot even see what you guys are scrolling down. So, I mean, I'm just on the blank, and I know you guys are working hard, and I totally get it. Like, trust me, when I was giving in 2021, when I was giving those immunization shots for the COVID, yeah, I used to work like 7 a.m. to 2 a.m. in the morning. And yes, whatever you guys hear, that's true, like 15, 16 hours. So totally understand it. I want to do this one right. We are trying to do this right since I joined as a board member. And I'm like, I cannot even see anything. I don't have in my iPad, so I can't even open it. So of course I don't have any question.
Sorry about that. Board Member Pineda.
Board Member Pinedo, nothing to add at this time.
As Board President Joyce. Yeah, it's unfortunate we couldn't have a little bit more transparency. Everything was kind of last minute this morning, and did the best we could considering the circumstances.
So
Gary,
this
did you
is,
have-
sorry, I
Go ahead.
cannot raise my hand. Anyway, sorry. So I just wanted to ask, and sorry, I was like, seriously. So I just wanted to ask, like, why didn't we just little bit delay? Like, why can't we just do 2:30 p.m. or maybe 4:30 p.m., right? I totally understand it's really tight deadline and everything. That's only one question. At least if I have like 1 hour to look at the document, because we know we all want to do the right thing, right? We always want to do that. Make sure we do it right before we release to the public and licensing. That's only one comment I have. Thanks.
That's Executive Director Runyon. Yeah, I appreciate that comment. It's a very valid question. The only thing I will tell you is that this was very intentional, and there are multiple agencies and associations and individuals involved in the orchestration of all of these processes to ensure that they align with other processes and coalesce with derivatives of those actions, to ensure that all of this is done appropriately within the projected timelines. So all of that to say, there's a lot of things I can't talk about, but while I do, apologize for the inconvenience or the, I guess, lack of better options. This was the best of all possible options given the state of everything else that has come before this and will come after this, and all of the other individuals involved. And in terms of not being able to see the information, I do apologize for that. But if you can rest your hat on anything, or rest assured that these are valid, I just look up on the screen and see the American Academy of Pediatrics, American College of Obstetricians and Gynecologists, American Academy of Family Physicians, and I know what work has been done at the West Coast Health Alliance and what work their partners have done. The PFAC reviewed these, I reviewed these, and it was a direct copy and paste. But I do really appreciate your concern about doing things right, and I'm of the opinion that they have been done correctly, and I just appreciate looking up on the screen and seeing that it's not just us that are putting our stamp of approval on these recommendations, that it's all of these agencies as well. So, but thank you, Board Member Patel.
Yeah, thank you, Gary, for explanation. I totally understand. I really appreciate all your hard work. So thank you. No, totally makes sense. Thanks, my dear.
So this is influenza I've opened. So we need to go through this.
Executive Director Runyon now. We'll go probably a little quicker through the influenza. Again, numbers 1 through 9 are the same. We have the reference to the West Coast Health Alliance up top. We have the current strains between the different formulations, and those are direct copy and paste from the package insert as well. And then consistent with the previous iteration of this protocol in June, it's available for 6 months and up. Of course, selecting an age-appropriate vaccine is important. The vaccine schedule here is very simple. Basically, without contraindication, anyone 6 months and up can get the vaccine. That's a gross oversimplification, but for all intents and purposes, I think it's pretty accurate for the context of this conversation. Additional considerations for use, of course, some of these references, they actually come from a guidance document. I think it's reference 12. And we removed all of the ACIP recommendations and references. So these were all present on the protocol as it existed in June. So there's nothing new here. I know it's a lot of information, but you had previously approved this in June. Same thing with pregnancy and lactation. We have a lot of references to the package inserts there. And then comment A, essentially saying that pregnancy and lactation is not a barrier to vaccination. That's consistent with the recommendations up top from the WCHA. Same thing from the warnings and precautions, referring to prescribing information, rather, a lot there. And then all of those other items were present in the June iteration, so nothing new there. Same thing with contraindications. And again, you'll see the generic information about seeing the prescribing information for more details if there are some items on there that aren't covered or might need to be researched in additional detail outside of what we can succinctly provide in the protocol itself. Storage and handling, that's the same across the board. And then we have all of the references there.
Discussion?
Just Board President Joyce, Board Member Kroger, you had your hand up. Did you have a comment or question?
I can wait for round robin, President Joyce.
Okay, let's go ahead and start round robin then. Board Member Chin,
No comments.
Board Member Hall,
No comment.
Board Member Kroger.
Board Member Kroger. I just want to be clear around the something that Gary had just said. I'm not questioning the recommendations from the West Coast Health Alliance and these other organizations. The concerns that I was bringing up is really around how this is translated into a protocol that's going to be usable for the pharmacists in our state. So that is my concern, is to make sure that information was translated into a way that's going to be usable and avoid confusion and any other administrative barriers for those pharmacies in the state. So I just want to make sure that that's very clear, Gary, that the questioning is not about the recommendations of these vaccines and who should and should not get them. It's about making sure that this is a usable document for the pharmacists who are probably already in the midst of a very confusing and chaotic situation handling patient questions at this time. So I have no further comments on this one. Like you said, this is very similar to what we've had before. But with the COVID and some of those updates, that was the scrutiny that I wanted to be able to take a look at within the protocols based on these recommendations. Thank you.
Board Member Patel.
Board Member Patel, I just have comments. Yes, it's lots of confusion and people are kind of anxious to licensee in the Oregonian. Once whatever voting we done today, I would like that board staff kind of release the newsletter to all the licensee, how to translate this one into protocol and everything. So that's the only one comment I have. Thanks.
Board Piano.
Board Member Pinedo. I had nothing to add.
As Board President Joyce, just keep in mind, 18th and 19th, the ACIP meetings, and so just check your emails for any follow-up on that, of course. With that in mind, I don't have anything to add. Executive Director Runyon.
Okay. Executive Director Runyon, thank you everyone for your comments.
Hold on, I didn't get to talk.
I'm so sorry. My goodness. How could I forget? Board Vice President Kirkbride, please. I'm so sorry. Go ahead.
Can I look at the high dose language really quick? It's hard for me to see when we're scrolling really fast.
Sorry,
I just want to see how that was worded.
Let me go back. I was opening RSD. Just a second.
Particularly the
Probably 3.
dosing for the 18 to 64. I just want to see what words that they use.
Scroll there. It may not get there directly.
Wait. Oh, am I in the wrong section? Where is it? Or it may not be in there. Sorry.
Yeah, I may not explicitly. Executive Director Runyon, I believe in the vaccine schedule that would be included in all individuals 18 and up. The recommendations don't specifically delineate what products would be used or selected in that instance. So that would arguably be covered in point 2A of an appropriate influenza vaccine.
Okay.
Or we could, amend that to say age appropriate if you wanted that to be more specific.
This is Board Member Chin, and I know that there are high-dose flu vaccines that are specifically for immunocompromised patients, but they're advertised for anybody over a certain age, and that's not necessarily found to be, I think, clinically significant difference. But I think that there are high-risk populations that need the high-dose flu vaccine. But I'm not thrilled about the advertising to anybody over a certain age that it pays a higher premium, but isn't really getting any bang for that buck.
Well, yeah, we can't do that. But what I'm
No, I
getting
know
at
that you're
is
not doing that, but I don't know in protocol that there's an age that you say that somebody should get the high dose.
no. But I want to make sure it's clear to pharmacists that they do have the option to use the high dose or the adjuvanted product for that category. But yeah, I don't think adding the word age helps because, like, to
No.
your point, Kat,
I think that an appropriate influenza vaccine makes sense to me, but I'm not in your pharmacy. I mean, that's using your professional judgment and your clinical skills.
Is that how it was before, Gary? It wasn't laid out with product selection?
Executive Director Runyon, I'm thinking back in June, I don't think we did, to be honest. I think we were inching towards, and I'm basing this off a conversation I remember related to the RSV vaccine, where a new vaccine had come out, but because we had specifically mentioned the names of the vaccine on the protocol, that one could not be included, so we ended up taking them out. But I believe staff member Melvin's going to pull up the previous one. But I think we were getting away from listing all of the names of the products.
Doesn't matter which one.
No.
Because remember how we had two?
Difference, yeah. I know there were some names up top on this one, but then I don't think the name of the products were listed. Yeah, you can see in the protocol recommendations and the vaccine schedule, they didn't make it down there.
I'll share my screen really quick. So our staff member, our most recent version was 12 of 2024, I believe.
Mm-hmm.
So this is what this is.
Okay.
Okay, so
we have the names.
I just saw it. Go scroll up a little. That's that line right there. Number D. Letter D.
And that's Executive Director Runyon. That's an ACIP recommendation, which we don't have. We can't currently put on there. We're moving away from. And I would say it's possible that other recommendations or additional recommendations could come out even from the WCHA in between now and our next meeting in October. I'm not sure what they have on the docket, but yeah, because that's an ACIP recommendation, we're moving away from that. We struck that or removed it.
So WCHA did not include that in their recommendations, is what you're saying.
Executive Director, and that's correct.
Okay.
Yeah, it's that just the table in 3 that I copied and pasted.
Okay.
Alrighty. Is this going to be as revised?
Board Member Kroger has her hand raised.
I'm sorry. Can't see that. Okay, Board Member Kroger, go ahead.
Board Member Kroger, sorry, I turned my camera off because I'm the call's getting a little glitchy. So my question goes back to the line of thought that Board Member Kirkbride just had. So are we saying that that recommendation for high dose vaccine does not exist now because we're moving away from ACIP, even though ACIP had reaffirmed their previous recommendations, and that's why we had the flu shot that was already active and in use within Oregon, which I think is maybe a question that was, asked earlier around why are we pulling flu when flu was okay? It was just COVID that was really kind of the holdup in this current situation at this current time. So are pharmacists not going to be able to immunize as described around high dose for immunocompromised or for age specific decisions, because that is not included in the what's the acronym, so I don't have to keep saying that well, West Coast AWCHA. So it wasn't included for whatever reason, but it was included because it was reaffirmed by ACIP earlier this year. So are you following my questioning, I guess?
Exactly, Director. And yes, same thoughts I had in the tight timeline in turning this around. And I think part of the impetus for this is basically to preserve this expanded access to care, because we're not certain what recommendations are going to come out of this. We have obviously more control over this at this point than we do just assuming that something viable is going to come out of ACIP and they're not going to further restrict vaccine access, which there are certainly indications to suggest that might be the case, or it's more likely than not. The other thing I think as a practicing pharmacist, if I try to put myself in those shoes again, as Kat mentioned, maybe in number 2A that I could get there to, in using my clinical judgment, Rachel, if you want to scroll down, of choosing an appropriate influenza vaccine, that I could get there through that determination rather. And even though it's not explicitly included, I wouldn't construe the protocol as presented to exclude it. Though I understand the kind of ease and the push for explicit inclusion or spelling that out where it's appropriate. But I believe, again, that was the impetus for not including those ACIP recommendations, because we are not certain what is going to come out of those meetings, and we don't have necessarily any control over that.
Okay, Gary, that's a wonderful explanation. I appreciate that, and I think that just because it's not included doesn't mean it's excluded from that. So I appreciate that. I think that's more the general direction I'd rather go when it comes to professional discretion, professional judgment, and decision-making standard of care practices. So thank you for explaining that. But I think
that's where that's.
But I think our pharmacists are used to, if it's not included, that means we can't do it, right? That is something that they have gotten very used to. So I think your explanation is really helpful. And as long as we make that clear in our communications, then this is perfect. And Gary, that was really wonderfully said. Thank you.
RSV. And then the other standard vaccinations.
Okay.
So we're running.
Executive Director Runyon. All right, we will now scurry on over to the RSV protocol, which is the smallest of them all, so we should be able to get through this pretty quickly. Again, in the What's New section, we have the WCHA reference there, the immunization protocol. This is in line with the FDA recommendation. So really similar to what we saw with the influenza recommendations. There really isn't much difference here. We're just taking this out so we can create that cornerstone of the recommendations that we have arguably more control over, that aren't going to change based on the politics higher up at the federal level. So here we have in alliance or in alignment with ACIP recommendations, 75 and up, universal recommendation. I think in April, they lowered the restriction from 60 through 74 with high-risk conditions to 50 through 74, which you see reflected here. And then we have an option for pregnant patients to receive that, and there's no age restriction inherent to this recommendation, and it's 32 to 36 weeks gestational age. And here's a copy and paste again of the recommendations from the WCHA, along with a few references there. You see the high-risk conditions in number 4, that'll take you to the CDC site, and then a very sparsely populated auxiliary section referring individuals to the package inserts for pregnancy and lactation, warnings, precautions, contraindications, storage and handling, etc. And that's the same language that we have in all of the others. And that wraps up the RSV protocol. Go back to the top, take any questions on that.
Any, just raise your hand on any questions on the RSV protocol. So,
Board Member Pinedo did have her hand up before we started.
okay, did you have a question regarding this section? Otherwise, we should move on. I can't hear you.
Oh, you're on mute.
You're on mute.
Sorry, I just had a question. General, if APA does come out with their recommendations, which they will, whether they're strict or not, we do have, and we will have, licensees that prefer to follow ACIP, and their recommendation is kind of an eggshell thing, you know, because you will have pharmacists that may or may not agree with the vaccines and protocols that we have put out right now. How do we let licensees know that if they choose to go with recommendations from ACIP, that they don't have to be afraid of reprimand by going that way versus the other way?
It's Executive Director Runyon. So I don't know that if we go this route, again, this is not legal advice, board counsel on it, feel free to jump in wherever. I mean, this would direct them, depending on the vaccine type that they're using, it would no longer direct them or authorize them to use ACIP or anything outside of this protocol to prescribe and administer the vaccine. Right. So if it's, let's say, the MMR that is still in that universal protocol list and does reference ACIP and nothing changes, then they would be authorized, if acting within the confines or authorization of that protocol, to administer the ACIP recommendations. But since those are changing, they, as I understand it, wouldn't be able to just do that under ACIP recommendations for these carve-outs because they no longer reference ACIP.
Is that clear? Remember, Pineda? Does that answer your question?
It does answer my question.
Moving.
Then I recommend, Stefan, that we open each of the standard vaccination protocol versions that are being amended and or repealed, and then have discussion at the end.
That's good.
In lieu of our time problem. Okay. I will share my screen, and then staff member or Executive Director Runyon.
Executive Director Runyon. So here is just a part of the process that I mentioned to begin with, where we're striking these carve-outs from the universal protocol.
And changing the version.
And obviously changing the version to reflect when we're doing that.
That was the 18 and older. One. Oh, did you need to say anything about treatment care pathways? We did not amend. I'm not going to open them. Okay. So 7 through 17, that's the.
And we had done this in a parallel manner across all of the appropriate universal protocols, depending on the age.
And then this one's complete repeal.
And that one you just saw was completely repealed because the only two things on it were coronavirus and influenza. And of course, we're pulling those, both of those off, so there would be nothing left on the protocol. So same case here.
We are not changing managing adverse.
Correct.
Okay, back to President Joyce.
All right, so are we ready to motion or should I ask? But let's go around just one more time. Or yeah, let's go around. Any additional questions? I'm just gonna go around. Board Member Hall, start off with you.
No additional questions. Thank you.
Member Kroger, that last section. Any questions? Okay.
Board Member Kroger, no questions.
Board Member Patel.
No question.
Board Member Pineda.
No question.
Alrighty. Board President Joyce, no questions. Board Vice President Kirkbride.
I just want to clarify one more time regarding Board Member Pinedo's statement. So there is that statement letter D on the protocols. I saw it on the COVID, I saw it on the RSV. I actually didn't look on the flu. That says you can follow ASIP or WCHA. So the way that you answered Board Member Pinedo confuses me because I thought I heard you say if you are using these three protocols, then you cannot follow ASIP. So I don't know why then that statement is in there that says you can follow ASIP or WCHA. So can you speak to that?
Yes, Executive Director running it. It actually, as I read it, it doesn't say we can follow ASIP. It's talking about co-administration of vaccines. So it's basically saying you can administer, this is coronavirus, you can administer coronavirus vaccine with any other vaccine. That's essentially what it's saying. So it's about co-administration, not following the protocols. Just saying at the end of that sentence, there's no need to separate them by 2 weeks. So we were just essentially saying because there are vaccines on our protocols now that will either be WCHA recommended or ASIP recommended, that you can co-administer any of the vaccines, essentially is what that's saying. It's not saying you can follow ASIP protocols.
Okay, is that what the RSV one says too? Is that the same language?
Yes.
I guess I just
It
misread it
should
then.
be.
Okay. Okay.
Board Member Chin.
I
I'm sorry.
totally misread that then, and I wonder if other people will too.
Ready, Board Member
Board
Chin.
Member Chin has no further comments.
All right. So,
Board Member Kroger has their hand
Board
up.
Member Kroger. Oh, I'm sorry. I can't
Board
see
Member
that.
Kroger.
Go ahead. Go ahead.
Sorry,
Board Member Kroger.
I think we need to be very careful when we talk about ASIP protocols. ASIP does not create protocols, they create recommendations that we use for
Recommendations,
our
right.
protocols. So I think we need to be really careful when we speak about that to prevent additional confusion amongst
I think.
this
thank you
here
for-
and in the.
All right. Thank you for the clarification on that. All right. Everyone's had their chance to speak. Is there a motion to move to adopt temporary rule OAR 855-102-0130? I'm sorry. Okay. Is there a motion to move to adopt temporary rule OAR 855-155-0345?
115. Sorry.
Is there a motion to move to adopt temporary rule OAR 115-0345 as presented to be effective upon filing?
So move, Board Member Chin.
Is there a second?
Seconded, Board Member Kroger.
Board President Joyce, yes. Board Vice President Kirkbride.
Yes.
Board Member Chin.
Yes.
Board Member Hall.
Yes.
Board Member Kroger.
Yes.
Board Member Patel.
Yes.
Board Member Pinheiro.
Yes.
Motion passes. Is there a motion? motion passes unanimously. Is there a motion to move to adopt temporary rule OAR 855-102-0130 as presented to be effective upon filing?
So move, Board Member Chin.
Is there a second?
Seconded, Board Member Kroger.
Board President Joyce, yes. Board Vice President Kirkbride,
Yes.
Board Member Chin,
Yes.
Board Member Hall,
Yes.
Board Member Kroger,
Yes.
Board Member Patel,
Yes.
Board Member Piana.
Yes.
Motion passes unanimously. We will now discuss a joint statement on vaccine administration with Executive Director Runyon.
Executive Director Runyon. We've been working furiously behind the scenes with the governor's office, with OSBN and OMB, and to address all of the questions that have come out in the last couple of weeks, just to make sure that all of our licensees and their licensees and members of the public have the most up-to-date and accurate information so they can make informed decisions as to what's appropriate for themselves and their family members. So we worked with OSBN and OMB and the governor's office to craft this guidance document related to prescription standards, as there was a lot of kind of confusion and questions around how individuals can get vaccinated in this interim period between FDA approval and the release of federal guidelines, or now we have the WCHA guidelines there. So we came up with this guidance document, and it's available on their websites as well as ours. Or I think it may not be on our website now.
It will be.
Yeah. So you can scroll down there. So it just talks about the scope of practice for different licensees, depending on the board, how individuals could get vaccinated, and granted, now that we have these recommendations and upon filing, this may not be necessary in most situations. In certain limited instances, it still applies, but this was an urgent need that we met together to fulfill, I think about a week ago, and just brought it for your awareness.
All right, is there any discussion? Just raise your hand on this portion on the joint statement. Are there any questions or comments in addition? Go ahead, Board Member Kroger.
Board Member Kroger, can you bring the statement back up, please? So I can see it.
Just go.
And then scroll to, I think there was a section around the pharmacist piece. I'm concerned and confused and would like to better understand the must include the phrase to administer at pharmacy and where that is coming from. I understand all prescriptions must have directions for use, but why must it include the phrase to administer at pharmacy? There are many ways to provide directions within a prescription. And if this is somewhere in statute or within rule that I'm not aware of, please enlighten me. But I'm concerned that this is in there. Thank you.
Executive Director Runyon, I appreciate the comment. I agree with you, there are multiple ways to suggest that or indicate that. And those multiple ways, I think, are further spelled out in a more recent FAQ that I think we'll see coming out sometime soon. So I think that's been further addressed and perhaps more appropriately delineated than what you see here.
And I'm not sure that prescribers have necessarily been aware of that phrase needing to be included on the prescription. I know a lot of people are being asked to write prescriptions. This is Board Member Chen, to write prescriptions for the COVID vaccine, but I don't know that every prescriber is aware that that phrase needs to be on there. And a lot of prescribers have their staff pen up those things and get signed by the prescriber. So, it worries me that if that's on this, that the pharmacist won't feel like they can do the administration if this is that phrase on here.
Executive Director, and again, this it is not on our website and will be essentially superseded by more up-to-date FAQs that address that in a different way.
Okay. And no must is going to be on there.
Pardon?
No must will be on there.
Can't speak to that part, but as I recall, it's more broad in that there isn't a other than the directive, whatever that might look like. There isn't a specific verbiage that must be used. It's just the directive itself for the pharmacist to administer that it focuses on. So that part, I believe, must be on there, but it doesn't have to necessarily take any particular shape or use any particular language.
Was that question answered, Board Member Chen?
I
Or
guess
clarified?
I'm gonna just have to see what happens when, when I hear back from people who are prescribing and what happens at the pharmacy on if they are getting the vaccine, if they're giving the vaccine.
Sorry, staff member Ekmoth. I just wanted to share that the communication that staff has been sending that we have received inquiries related to clarifies that the prescription must have directions included to administer the vaccine, but there is no specific language required. So it could be or that terminology or something similar, and we are going to have broader communication to make sure that that is clarified across the board, but that is what staff has been communicating with inquiries we have received.
Does that clarify your question? Sorry.
I'm just curious why there needs to be a statement at all if there's a prescription to the pharmacy, if that's not implied that the pharmacist is being directed by the prescriber to administer the vaccine, because we're not going to build the vaccine and give it to the patient.
Executive Director Runyon, while I do understand that, I believe it's Division 41, Operation of Pharmacies, 1105, General Prescription Requirements. There are two elements that constitute the need for that, and it's you must fill the prescription in accordance with prescriber authorization, and the prescription also must include directions for use. So I think that's where that comes from, because if the pharmacists weren't going to administer it, what directions would be on there, right? Okay. They wouldn't be directions for patient use, yeah. So they have to put some things. I think that's in part where it comes from.
That I understand that then.
Okay, I'm just gonna go around. Board Member Patel, do you have any comments on the joint statement?
Well, no. Well, I can see both sides, and I'm kind of person. As you guys know, I don't like too much verbiage. Why we have to write down everything must not, just say pharmacy to administer vaccine, why we even have to write down? But as long as we are not going to take punitive action on those, then I'm fine with it. I don't know however you word it. If you really have to word it that way, go for it. But as long as we do not take punitive action on the licensee just because it's worded, not worded, worded differently, anything like that. That's what I stand for. And another one because I can raise my hand. So how long this is going to last? I'm staffing today, so I'm just kind of like, it should be 11:30 to 12:30. So I don't know if it's going to take longer, then probably I have to leave the meeting. Thanks.
Yeah, we're done. We're at the end of the section.
Okay.
Just want to make sure, everyone had the comment on the joint statement, then we're gonna adjourn, okay? So Board Member Pineda? Or
Board
did you
Member
have anything? Okay, go ahead, Board Member Pineda, please.
So if the prescription comes over with just use as directed or administer as directed in the SIG, we would have to call the provider's office. And do we even at this point, now that we are publicly putting out all of the protocols or they're being sent to be approved, do we still require the prescription now at this point? No, correct? So is that statement that was made going away now?
Executive Director Runyon, I think it's a non-issue. Just for transparency's sake, we brought this to you because I was minimally involved in it. It was a time-sensitive thing. It was a directive that we were given very little time to execute, and in partnership with the two other boards, we did that. Again, it's going to be superseded by updated FAQs that I think aptly address Board Member Kroger's question, which I appreciate, very soon. So I don't think this is an issue at all. And again, in line with what Staff Member Efremov has said, it doesn't reflect the communications in terms of addressing this question that we have been sending out at the agency level either. So this was just more of out of the sake of transparency, this thing went out, it had our seal on it, we wanted you to know about it, but it's not on the website, and it's going to be superseded by those other communications very, very soon.
All right, anything else before I move on?
This is Board
Okay.
Member Chen. So what I understand is that once we've done the vote, we're going to close the meeting, we're going to file these temporary rules. Once they're filed, then we're going to send out a communication to all our listservs that pharmacy can start doing the vaccines the way we wrote our temporary rules.
Executive Director Runyon, that all comes back to, I think, what Board Member Patel had asked. Everything is intentional, so there will be communication when it's appropriate for us to do that, because there are other forces involved and agencies involved, and there's a lot of necessary orchestration behind the scene related to this. So we will definitely put out that communication when it's appropriate and when we're directed to, which should be very soon, but it's intentional. It may not happen exactly at 3:30. But
3:35.
Yeah, 3:35.
Board Vice President Kirkbride, did you have anything to add or clarification needed?
I have nothing to add. No comments on the statement. I do appreciate the communication the board sent out on the 5th by email and on their website. It was very succinct and very direct. So thank you for that regarding COVID vaccine.
And Board Member Hall, lastly, do you have any questions or clarification before we adjourn?
No additional comments.
All right, so we will be adjourning, okay? Is there a motion to adjourn the meeting at 1:13 p.m.?
So moved. Second, Board Member Kirkbride.
I'm sorry, who was the first? I didn't catch it.
First?
Yeah.
Yeah.
Okay, first was Katchen.
Second was.
And second was Kirkbride. Board President Joyce, yes. Board Vice President Kirkbride.
Yes.
Board Member Chen.
Yes.
Board Member Hall.
Yes.
Board Member Kroger. Adjourning. Frozen and gone. She there? Are you there?
She's on mute.
You're on mute, Board Member Kroger. We're adjourning the meeting, yes or no? I'm gonna,
So
All right.
yes,
Yes, my
Yes.
my laptop or my
I got you.
iPad.
Okay.
So go ahead, adjourn. Thank you.
Board Member Patel,
Yes.
Board Member Pineda.
Yes.
All right, motion passes, meeting adjourned.
Thanks, everyone.
thank you.
Thank you.